Yes, sir.
Thank you. Thanks a lot. So, so starting how to choose an antibiotic for UTI, as I said very at the very beginning, this is something which everybody is treating and everybody will be treating in their medical career. Surgeons, medicine people, even in our place, many of the basic MBBS students also they treat and urinary tract infections. And antibiotics, as we know, for medical professions like bread and butter, and everybody uses it like an over-the-counter medication. So before we go ahead, there are few things. The most important principle of antibiotic usage is how not to use antibiotics. It is not about how to use, it is about how not to use antibiotics and how to use it as minimum as possible. It's not to give as long as possible, it is to give as minimum as possible. That is the principle of using an antibiotic. Having said that, let's go ahead with what we know. And a very basic thing, a urinary tract infection, when we talk about it, you can have, the most classical presentations that we read about is the high grade fevers, the pain in loin, the chills, the rigors and all, which is technically the pyelonephritis. And I have already seen Dr. Narayan Prasad is there, and something which he would be treating day in and day out. And this is what you see when you think about classical urinary tract infections. But very commonly, we keep on missing out on what is the basic cystitis and prostatitis. Many of the times they have minimalistic features, might be something as simple as just a malaise, or it could be something even with a bit of hematuria or a burning maturation, increased frequency and all. Then, of course, you can also classify a urinary tract infection like respiratory tract infections into the community, whether it's a community organism or you are getting it from a hospital acquired infection. So that is another way of actually classifying it, because that determines what sort of antibiotics you are going to select, whether you're going to go for a higher end antibiotics or you're going to just use the much lower narrower spectrum antibiotics. Equally, when you also think about urinary tract infection, you also see with age, with lot of specifically females and elderly and all, the recurrent UTI, relapse of UTI, or a reinfection of UTI. There are definitions of each of them. I'm not going per se into it, but it is something one has to remember. Incompletely treated is just like a relapse, but a reinfection is something which after multiple treatment and after you have seen clearances, again the patient has developed reinfection. Then it is can be simple or complicated, which we have all been taught. That is those simple which are basically technically there are no anatomical or such issues, or complicated where there are basic underlying certain conditions which lead to increased urinary tract infections. Nowadays also in certain places, the infections which are going into the upper tracts are considered complicated, but technically we consider anatomical or underlying conditions which predispose to urinary tract infections as complicated UTIs. So clinically, as I said, the fever, chill, and loin pain, the classical ones are basic of upper tract. To the limit, for us as an infectious disease specialist, even if I do not have a imaging, even if I do not have that, if the person is coming with high grade fever, chills, and loin pain, uh, uh, I would still consider it as if the infection has gone up into the upper tracts as compared to somebody who's just having urgency, frequency, and hematuria. Then one important thing which has to be considered is asymptomatic bacteria, which most of the times in most conditions you wouldn't be treating, apart from specifically one important place is pregnancy. If you look at the latest, many of the guidelines, very simply, if you look at it, acute cystitis, as I said, is presumed to be confined to the bladder, and there are no signs which are going into the upper tract, and any other signs which come up, which you see like fever, chills, even abdominal severe pain and all, they will be considered as those which are leading to complicated UTI of the upper tracts. So this is a small case scenario which we had put earlier, that suppose a female comes with a high grade fever and chills and pain in left loin, and of course you all make a clinical diagnosis of a pyelonephritis. The point now is, what do you do after that? The most important thing is, of course, you would look for the general examination, so look for other comorbid conditions or maybe underlying pregnancy, and you would also look at the severity of the disease. This is something which has to be clinically examined. There is no test, nothing which is going to determine that. You have to do the basic clinical examination, decide whether the patient is severe, the patient has a history of possibility of admissions in the past 90 days, and there is usage of antibiotics or not, and specifically certain broad spectrum antibiotics. All these histories have to be taken while doing the examination and taking history. And then of course you have to send a urine for examinations. This is basic protocol which everybody knows. Having said that, the most important thing is proper sample collection. A proper sample collection is something which we all forget about. That includes both in a person who is coming to your OPDs or who is walking into your clinics, or a person who is moribund and is catheterized. One of the most important things one has to remember is, if you want to treat and select the proper antibiotic, then you have to have proper sample collection, and which I hope it has been discussed in the previous lectures which have been conducted. But if not, one simple thing one has to remember, apart from the clean catch urine samples and the midstream, which were all taught in specifically hospital setup, one should know that when you are taking the urine out from the catheters, it should be properly cleaned, and the you should remove the urine should be out from the catheter, and then you should put it not, and the Foley is the 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 bulb of the Foley where you actually where the catheter is joined, there you have to clean it and then take it out with a syringe. You have to pierce it with a needle and then take it out. That's how you should take a clear catch for a catheterized patient. If you have done that properly, then you shouldn't have false positive bacteria. You should have a properly, if you are isolating bacteria in such conditions, then most probably then you are getting a true urinary tract infections. And equally, whenever you have this, you should always see that there should be WBCs. Without WBC, if you are getting bacteria in rare conditions only, it would indicate, otherwise it would not indicate of major infections. Role of imaging is definitely there in managing urinary tract infections. Ultrasonography, CTs, MRIs, all are very important. And but one has to remember that in pyelonephritis, though USGs are very important, for any clinician point of view, I would suggest one thing, that if the patient's symptoms are suggestive of pyelonephritis, even if your USG is not showing much, consider it to be pyelonephritis. CECT, of course, is a highly sensitive test which would in most cases indicate and catch not only pyelonephritis, and it will also give a better idea about possibility of emphysematous pyelonephritis and other conditions. Bacteria in a catheterized patient is something which is very common, and which is something which you especially in a tertiary case super specialty hospital would be seeing, where there will be long standing indwelling catheters, and then the risk of infection goes up. And of course, in your hospital you'll also be having OPD patients coming with clean intermittent catheterizations, where of course even there you have got to 1% increase in bacteria per day. Finally, coming to the basics of choosing an antibiotic. Now, choosing an antibiotic is something which varies from person to person, clinician to clinician, but there are certain broad guidelines which one has to follow while selecting an antibiotic. One of the first thing that you want to do is you want to know about the pharmacokinetics and dynamics of an antibiotic. You should know whether an antibiotic actually has a penetration into a viscera, whichever place you are using, not only for urinary tract, wherever you are using, one should know about the penetration of an antibiotic in that viscera or in that area where you want to treat it. Secondly, you also want to see the possibility of whether this patient might be having a drug resistant organism. And thirdly, you want to be careful what you are selecting as per the severity. If I have a cystitis patient, as a rule, I do not start antibiotic until and unless I have the urine examination reports in my hand. The patient is having mild infection, and the patient is having increased frequency. The patient might be having burning micturition. It's better to give symptomatic and wait till you get the report and then start the antibiotic, unless of course the patient has some immunocompromised state or critical conditions which might be there underlying. Otherwise, there is no hurry in starting an antibiotic. That is something one has to remember. Third, how long do you give an antibiotic? It's not, that is something as a principle one should always know. So antibiotics are there. There are lots of guidelines, lots of studies, and in different areas, people have said cotrimoxazole, that is, was usually a Septran, or we get it as Ciplin. It's a very good antibiotic. Quinolones are great antibiotics. beta lactams tend to have a lot of which are used commonly and regularly by everyone. Ceftriaxone has become like a bread and butter for uh, all clinicians, and the nowadays even piperacillin, tazobactams, and meropenams have become like, it's just like if you don't have bread and butter, then you jump on to the next thing like a paratha. Everybody starts using them, but one has to know what you are trying to treat. In females, post, suppose I have a patient a female patient who has just been operated, who has had a delivery, and there are different set of organisms which would be common. In most cases, E. coli is something is which is always common in most series of studies, but enterococcus and all, they start increasing in certain group of patients. In those who have been hospitalized, who have been regularly catheterized, of course there's a tendency or possibility of pseudomonas and all, so that has to be kept in mind. So choosing an antibiotic that includes the class, the culprit, and the culture sensitivity pattern of the department and institute. And the class of patient includes no contact with healthcare, no prior antibiotics within 90 days, contact is, so antibiotic use is there, or age is greater than 65 years, hospitalization for more than 5 days, and there is a recent use of multiple antibiotics. Specific, there are certain group of antibiotics which have to be kept in mind. And then, of course, there's a possibility of severe sepsis, invasive fungal infections have to be kept in mind, immunocompromise, and then in rare cases, and in those specialized cases like pregnancy and renal transplant patients, which you will be seeing very much in your setup. Therefore, one important thing, which is baseline, which has to be there for any institute, which I feel and should be there in present scenario. Maybe 10 years back, we were not thinking, but now with each year, it is important that every institute, every unit should have its own antibacterial resistance pattern. Of course, you need to have at least 30 isolates in most of the cases to have an antibacterial resistance pattern. And you should have an antibiogram. And finally, an antibiotic policy, empirical policy should be there for each institute, which should be followed. Here, when we do that, what we have seen in the last 5 years while running antibacterial stewardship program, it varies so much. And KGMU, if somebody has seen, there are multiple buildings and there are different departments in different buildings. If in my building, what we have seen is we still have a lot of sensitivity with for our gram negatives for even for aminoglycosides. But in another building, which we have a Shatabdi group of hospitals where there are lots of cancer patients, there we have seen that even the meropenams tend to be resistant. So it is so different from each building to building, depending on what clinicians are using which antibiotics, that the whole milieu changes. So it is highly important that all institutes should have an antibacterial resistance pattern, antibiogram, antibiotic policy, and an antimicrobial stewardship program, which not only includes this, it also tells you what antibiotic to be given in what place, what system, what dose, and what route. That would actually give you the best benefit and is mandatory. So these are the different drugs which you should remember about. Use of fluoroquinolones and or cotrimoxazole or broad spectrum beta lactams like third generation or later generation cephalosporins, if they have been used in the last 90 days, and definitely one should think of that the possibility, if the patient is coming back with a UTI, then he has a MDR UTI. Then there are certain countries which are known to have that. India definitely is in that group of countries. So one has to be careful about that also. So these are the broad culprits which we all know, which we commonly see, which you are also seeing in your own wards also. So the ideal antibiotic, which has high and prolonged concentration in urine, which has broad spectrum activity against most uropathogens, and which requires short length of treatment. We do not want to give a long length of treatment. We do not want in a critical patient to start off with something like with a bacteriostatic drug. I'm not interested in, I don't prefer as a clinician to start off as a first choice as a linezolid because it's there. Because linezolid is actually a bacteriostatic. I would hit it fast with an antibiotic if I have a culture with something which is fast and which needs shorter course and has infrequent dosage schedule. So those you should always avoid. So for most complications, if somebody has cystitis, I would, and most studies suggest a very short course. Short course is what is important. But unfortunately, what we keep seeing is even for a cystitis, people keep on giving them 7 days, 10 days, 14 days, 15. No, no. You just need to do 3 to 5 days. That's the maximum period of things which is required if you are treating a lower uncomplicated infection. That means the patient does not have recurrent infection. The patient is not having any anatomical or any other underlying comorbidity which can lead to the deterioration of the disease. So the most common ones, which actually are cotrimoxazole, ciprofloxacin, which is a very good antibiotic. I would prefer that over a moxifloxacin in a urinary tract infection where I have to hit more for gram-negative bacteria, whereas moxi is a better antibiotic for an upper respiratory tract infection or where I'm trying to treat a tuberculosis, but not for these sort of patients. So that is something one has to remember. Then, of course, there are beta lactams which are always used, nitrofurantoin, and recently we have got a lot of data coming about how phosphomycin is also pretty useful. In critical patients, of course, you have to put a lot of things, and here you have to, of course, save the patient, and that includes where you have to think about the possibility of MDRs, non-MDRs. And in such scenarios, you want to give a much broader spectra, and you're not going to wait for the culture reports to come. You will start off with an empiric treatment, and then once you get the culture reports, you start downgrading. The downgrading should be very sensible. It is many times you see an enterococcus coming positive, and the patient also, and which might be sensitive. For example, in what we said, it's sensitive to both amoxicillin, one of the first generation penicillins, or piperacillin tazobactam. Still you want to continue with vancomycin. Well, that's not correct. Penicillins, even to date, where sensitive, are much faster than this. Of course, you might add an aminoglycoside to give a broader coverage and keep it under control. But that actually not only saves the cost of the treatment, it also helps you in not allowing other drug-resistant bacteria to actually to the risk of developing more MDR infections. In those who are other hospitalized patients where the risk of MDR is not there, a quinolone, if severe, then you can use broad spectrum beta lactams, or you can also stick to the third generation cephalosporins, where possibility of enterococcus, or you have an isolate. One of the best methods is when you send the microbiology department, which I keep asking my microbiology department also do, even before you give me the culture, just give me whether the staining shows a gram positive, cocci, bacilli, whatever, then you give me that. We'll start off according to that. There is no point you give me for 5 days. Even if you give me this much, then I can actually restrict the antibiotics accordingly and not wait and keep on waiting for 3 to 5 days till the culture reports keep coming. For reinfections, well, there are a lot of causes. There are different types of regimens which can be used, but most commonly you can use, what is used is a cotrimoxazole or a nitrofurantoin, which is usually used every night, and every monthly cultures are done, and till you have a complete clearance of bacteriuria, and then after stopping that, usually you should repeat after 7 to 10 days of stopping the antibiotics. That is the usual protocol for most infectious diseases, that whenever you want to reculture, stop the antibiotic when you're sure, and then again do a culture after that. But having said that, before doing that, you please ensure that the patient's other basic requirements are taken care of. Many of the times, patients who are moribund, the patients get reinfected because of improper cleaning and improper hygiene, which is not maintained properly. So those are things which have to be actually looked after, and just not keep on treating. The patient is just having bacteria without any pus cells, I'm not going to treat. If the patient is asymptomatic, not having any other thing, I'm not going to treat a colonizer. That is something one has to remember, because if you keep on treating colonizers, you will keep on having MDRs and definitely will cause a greater problem for oneself. Fungal infections, well, most commonly fungal infections nowadays, as we see, which are increasing by day. And fluconozoles, of course, nowadays, if it's just an OPD settings, it is useful. But one of the ICU settings, we tend to get very resistant fungal infections and candidurias. Having said that, the first and foremost treatment in an ICU setting for any infection is replace the catheter, whether it is fungal or non-fungal. Remove the fomite if possible. If not, at least replace it, change it, then start any antibiotic. Otherwise, with the presence of biofilm, whatever you might do, whatever antibiotic you might use, you will still end up actually not clearing it completely. So that's my final slide. I don't know if you have any questions, but one thing is sure, the usage of antibiotics The proper usage is to use it as less as possible. That is the one single statement, and not to use it in extreme, and control the doses and be confident enough to stop it within the period and not continue it beyond that. Thank you.